Why advocate for home therapy for your patients? In this professional education module, you will gain knowledge and strategies to promote home modalities in your patient population, thus creating a pro-home culture where all patients are considered as candidates for a home modality. Topics in this program include understanding the basics of kidney failure, showing the transition between chronic renal failure and end-stage renal disease. We will break down each home modality, sharing the benefits, patient considerations, and shared tips for patient selection. This program will provide a high-level understanding of the mechanics of home hemodialysis and peritoneal dialysis, including equipment, supplies, training requirements, competencies, and support. We will share best practices garnered from successful home programs and provide resources to bolster staff and patient understanding of these modality options. Following this program, the learner will be able to verbalize the difference between chronic kidney disease and end-stage renal disease, discuss strategies to pair patient life plan and lifestyle with modality options to assist the patient in making a modality selection which is optimal for their individual life goals, provide factual education to patients on the benefits of home dialysis, list reasons to expand home therapy to patients who may not have been considered in the past, describe the best progression of treatment modalities as a patient transitions from CKD and reaches ESRD. Select and incorporate at least one proven best practice into your facility to increase home modality use, and select resources to drive change in your patient population. Let's start with the basics. How do normal kidneys work? The kidney's job is to filter the blood. Kidneys remove wastes, control the body's fluid balance, and maintain the right level of electrolytes. All of the blood in your body passes through the kidneys about 40 times a day. Blood comes into the kidney through a renal artery. Waste is filtered and removed, while salt, water, and minerals are adjusted. The kidneys process blood and creatinine through a process of filtration, reabsorption, and secretion. Urine is about 95% water and 5% waste product. Nitrogen waste is excreted in urine, including urea, creatinine, ammonia, and uric acid. Ions such as sodium, potassium, hydrogen, and calcium are also excreted. Each kidney contains over 1 million tiny structures called nephrons. Each nephron has a glomerulus. This is the site of blood filtration. The glomerulus is a network of capillaries. As blood flows through the glomerulus, blood pressure pushes water and solutes from the capillaries through a filtration membrane. Glomerular filtration begins the urine formation process. The filtration membrane allows water and small solutes to pass, but blocks blood cells and large proteins. Inside the glomerulus, blood pressure pushes fluid from capillaries into the glomerular capsule through a specialized layer of cells. The waste and small particles have been filtered out of the bloodstream and may contain substances the body needs, such as ions, glucose, amino acids, and smaller proteins. Some of these necessary particles are reabsorbed. At the same time as reabsorption occurs, secretion of the unnecessary waste is also happening. This simultaneously happening process is located in the renal tubules in the nephrons. The secreted ions combine with the remaining filtrate and become urine. The urine flows out of the nephron tubule into a collection channel, then passes into the ureter and down the bladder. Over 37 million American adults have chronic kidney disease, or CKD. It is the ninth leading cause of death in the United States, yet most people are not aware they have this illness or are at risk. Chronic kidney disease is defined as an irreversible loss of kidney function at the glomeruli or filtrating level of a normal kidney process. Chronic kidney disease is diagnosed with a simple blood test called the glomerular filtration rate. Creatinine is the waste product of the breakdown of dietary protein and is used to calculate GFR. Creatinine results are entered into a GFR calculator which estimates the rate of filtration taking into account a patient's age, weight, height, gender, and race. Patients with the risk factor of diabetes, high blood pressure, heart disease, and a family history of kidney disease should be tested regularly. The stages of chronic kidney disease are determined by the percentage of kidney function or glomerular filtration rate. Stage 1 is determined by the glomerular filtration rate or GFR of greater than 90%. Some of the kidney function is lost, but the kidneys are functioning at a normal capacity. Stage 2 shows 60 to 89% of kidney function or a mild loss of kidney function. Stage 3 ranges from mild to moderate kidney function with a GFR of 30 to 59%. Stage 4 shows severe loss of kidney function with a GFR range of 15 to 29%, and Stage 5 kidney failure with less than 50% of normal kidney function. Patients may experience the following symptoms throughout the progression of chronic kidney disease: chest pain, dry skin, itching or numbness, feeling tired, headaches, increased or decreased urination, loss of appetite, muscle cramps, nausea, shortness of breath, sleep problems, trouble concentrating, vomiting, weight loss. The nephrology team should educate the patient on strategies to preserve kidney function and, as disease progresses, treatment options. The patient has reached CKD stage 5 with 89 or 85 to 90% of the kidney function lost. With a GFR of less than 15%, the kidneys don't function well enough to keep the patient alive and some intervention is required. Modality options include transplant, peritoneal dialysis, home hemodialysis, and in-center dialysis. The symptoms of stage 5 kidney disease may include uremia or waste buildup, fatigue, shortness of breath, nausea or vomiting. Swelling may occur in the hands, legs, eyes, or lower back, and the patient may suffer from altered mental status. Nearly 786,000 people in the United States are living with end-stage renal disease, with 71% on dialysis and 29% who have received a kidney transplant. Patients may have options to consider as they approach CKD stage 5. As professionals, it is our duty to assist each patient in making modality decisions that fit their individual priorities and goals to ensure each patient thrives despite their kidney disease. Decision-making tools such as My Life, My Dialysis Choice by the Medical Education Institute or Choosing Dialysis by the Patient-Centered Outcomes Research Institute can help patients identify the treatment option that best fits their individual need. Transplant is a treatment option. In 2020, nearly 23,000 patients were transplanted. In August of 2021, over 90,000 persons were waiting for a kidney transplant, and the list is growing daily. To receive a transplant, the patient must undergo a series of tests to assure the transplant center the patient is healthy enough to receive and maintain the transplanted kidney. Although the transplanted kidney functions much like normal kidney function, the transplanted patient must take medication to prevent kidney rejection for the rest of their life with the transplanted kidney. Peritoneal dialysis has two options: CAPD, or continuous ambulatory peritoneal dialysis, and CCPD, continuous cycling peritoneal dialysis. Each option uses the peritoneum as a dialysis filter. CAPD is done daily with a series of 4 or more exchanges of dialysate using the peritoneal catheter and a gravity feed. CCPD occurs as the patient sleeps each night using the peritoneum as the dialysis filter and requires a machine called a cycler to make the changes. Home hemodialysis offers two options as well: home hemodialysis and nocturnal home hemodialysis. Both of these hemodialysis options use a compact machine which provides the treatment and makes medical-grade water necessary for dialysis. The patient and/or caregiver are trained on setup, use, and troubleshooting of the equipment needed. Home hemodialysis is done 4 to 6 times per week for 2.5 to 4 hours as ordered by the physician. Nocturnal home hemodialysis uses the same equipment and technology, but is done while the patient sleeps 4 to 6 nights per week for 8 to 10 hours each treatment. Nocturnal home hemodialysis and CCPD provide the greatest number of hours of dialysis weekly, allowing for relaxed fluid and food restriction, better electrolyte balance, fewer comorbid dialysis complications, and better lab results, leading to the patient feeling better and having more energy. In-center hemodialysis offers two treatment options: standard 3-time-a-week dialysis and nocturnal hemodialysis. Both of these options are staff-assisted. Nocturnal hemodialysis gives the patient slower treatment and promotes fewer dialysis complications. Nocturnal dialysis treatments are typically 3 days a week, 6 to 8 hours per treatment, providing more treatment time per week than traditional in-center dialysis. In certain situations, a patient may choose not to undergo treatment. The patient and their family members must be thoroughly educated on the risks and ultimate consequences when making this decision. Conditions for coverage VTAG 458 states all patients must be provided unbiased education of treatment modalities, including transplant, home, and in-center option. This must be documented annually in the medical record. Additionally, under the conditions for coverage, plan of care VTAGs 512, 513, 553, 5, and 554, the patient must be assessed annually for home modalities and transplantation. The nephrologist must provide documentation of this assessment. This requirement may assist facilities in increasing physician involvement in selecting candidates for home modalities and transplant. This slide shows the optimum path for treatment option selection to achieve premium patient outcomes as patients transition from CKD to ESRD. This treatment path is based on patient outcomes and survival rates. Preemptive transplantation is considered as the optimal treatment for renal replacement, with transplant being the treatment option closest to natural kidney function. Candidacy for transplant may be limited based on comorbid condition, age, and the wait time for a cadaveric kidney may be 5 to 8 years or longer. If further deterioration of the kidney function reaching stage 5 occurs, an immediate need for intervention is required while the patient is waiting for a transplant, or if the patient has not qualified as a transplant candidate, selecting a home modality option should be the next consideration. Peritoneal dialysis and home hemodialysis provide more treatment time than standard in-center dialysis option and lead to fewer dialysis complications. Thus, a better quality of life is achieved. The next best option for natural kidney function after transplantation is peritoneal dialysis. Peritoneal dialysis, or PD, can be initiated quickly. The PD catheter is easy to place. Training time is brief. The skills needed are fairly simple to master, and this modality preserves remaining renal function. Home hemodialysis should be the next treatment modality considered. The peritoneal membrane is responsible for dialysis can fail over time. Problems like recurrent peritonitis or abdominal issues can occur, necessitating discontinuation of PD. once the patient is comfortable and competent in their abilities at home and like the freedom of their schedule, they can often transition easily to home hemodialysis following additional training and competencies. In-center hemodialysis should be the last option considered as it provides the least amount of renal replacement therapy, the most restrictive diet, a high number of medication, and the least amount of patient freedom and control. For these reasons, all in-center patients should be regularly encouraged and educated on transplant and home modalities. Dialysis options are not a one-size-fits-all solution. There are many tools available to take into consideration the patient's individual priorities, goals, and pose modality options that best fit their needs. Some of these tools include My Life, My Dialysis Choice, individual organizations options classes, peer mentors with the National Kidney Foundation, and Choosing Dialysis, a tool provided by Arbor Research Collaboration for Health. Let's look at the facts. The current national average of patients dialyzing at home is only 12.5%. 93% of the nephrologists and 89% of the nurses surveyed said they would choose home dialysis over in-center dialysis. Survival rates are greater for patients who choose their own treatment type versus patients whose physicians choose for them, regardless of the modality selected. Many physicians believe that 25 to 35% of their patients would do better on a home therapy. It is a requirement for participation in Medicare that ESRD beneficiaries receive documented modality education at least once per year. When surveyed, 32% of patients responded and said they were not informed or educated on all treatment options. Patients who received early and frequent modality education, 50 to 70%, will choose a home modality. Patients who participate in the selection of a treatment option that best fits their needs have a higher quality of life and improved survival rates. In a person with healthy kidneys, the kidneys are working 168 hours a week. In-center dialysis patients receive on average 12 hours of renal replacement therapy per week. Selecting a home modality will increase the amount of dialysis a patient receives each week, thus improving many clinical outcomes. More hours of treatment leads to a higher KT over V, which is the measure of renal replacement. With slower, more frequent dialysis, there is a reduction of symptoms of comorbid conditions associated with dialysis such as sleep apnea, restless legs, nausea, and improved cardiac outcome is often seen. Patients see better blood pressure and fluid control and just feel better. More dialysis means less stress on the heart and lower mortality rates in this patient population. Patients dialyzing at home see fewer infections, which leads to decreased hospitalizations and ultimately lower healthcare costs. What are some of the things that patients should consider when looking at selecting a home modality as their modality choice? More frequent dialysis, which is associated with home modalities, provides treatment options which are more like normal kidney function and leads to a patient feeling better and having improved quality of life. Patients have better clinical outcomes. With home dialysis, there is more flexibility in their treatment schedule, so there is more time for work, school, and socializing with family and friends. The equipment is portable and allows for travel. With more frequent dialysis, patients may see a reduction in the medications they take, may have a more liberal diet, and see fewer dialysis complications such as nausea, cramping, and blood pressure fluctuation. Patients see little or no post-recovery symptoms, have increased energy levels, and just feel better. Every patient who has the cognitive and physical ability should get a chance. If the patients are challenged in these areas, they could be successful at home with a dedicated care partner or unique training approaches. Prior to closing the door on a home therapy for a patient, ask the patient what else we can do to be creative and get this patient home. The key is to find a patient who is motivated and dedicated to learning the skills needed to be successful at home and offering them the environment to succeed. Often the patient who is acting out or non-compliant in an in-center setting may thrive at home once regaining control of his or her life. Let's review a few case studies which may help you understand the importance of expanding your patient selection criteria and looking for creative solutions to transitioning more patients home. The following case studies show patients who provided challenges to the standard patient selection criteria. Reviewing each case may assist you in expanding selection to consider a less than ideal but motivated patient to move to a home modality. Case study number 1 shows a variety of challenges to accepting MS as a home candidate. Due to his size, noncompliance, and uncontrolled comorbid condition, this particular patient will be difficult to transition to home. MS was dialyzed in-center at the facility for 5 to 5.5 hours per treatment and often shortened his treatments due to family obligation and was extremely happy in the dialysis center and didn't feel well. He had a dialysis partner but lived in a very small walk-up apartment with limited furniture and 4 family members. He had limited space and storage available. Michael Sankey became a happy and healthy home patient when his physician gave him a chance to try home hemodialysis. Mike took ownership, performed all of his treatments from start to finish, and became compliant. At one point, Michael was the largest patient on home hemodialysis, dialyzing 4.5 hours, 5 days a week, with excellent lab work. Storage was a problem which was solved by family using space under beds and more frequent delivery of supplies. His hypertension and diabetes were better controlled and his medication was reduced. Mike felt so much better, so he was able to participate in family activities and enrolled in college. His increased participation in life also helped him lose over 150 pounds. Mike has since received a kidney transplant and works full time. Candidate number 2, LL, was very angry and distrusting of the dialysis staff. He had been dismissed from several dialysis centers due to his negative attitude and was dialyzing in isolation to prevent verbal confrontations with other patients and staff members. He was unemployed, depressed, non-compliant, and his ejection fraction was less than 15%. One-on-one conversations with home training nurse, learning the benefits, and with the promise of regaining control over his life, Louis Lipscomb decided to try home hemodialysis. Prior to starting training, Louis was proactive. He reviewed and studied the training videos on the Next Stage website and was armed with a page of questions. He mastered the skills and completed competencies without problem. He performed 3.5 hours of treatment 4 days a week without fail. His ejection fraction improved over time, his medication was reduced, and he felt remarkably better. With his improved cardiac function, he was now a candidate for transplant and successfully pursued transplant waitlisting. Lewis had more time to do things that were important to him in his home. He spent more time with his children, got married, completed job training, and went back to work full time. I am also happy to report he has received a successful kidney transplant. Case number 3, KG, is a 36-year-old stay-at-home mom who had been on dialysis for 4 years. She had chronic fatigue, was obese, and had no ability to care for her children or freedom to pursue her interest. She lived in a remote location and wasn't aware other treatment options were available. After a conversation with family members in other state, Kim became interested in peritoneal dialysis. She researched online and asked the charge nurse in her facility for help learning about PD. She pursued lap band procedure to qualify for the modality and lost 80 pounds in 5 months. Once qualified, within 2 weeks, she had the catheter placed and had started training for CAPD. Doing her treatments at home has given her endless energy, allowing her to spend more quality time with her children and the ability to pursue the volunteer duties at her children's school she always wanted to do. She has an active social life with family and friends and has taken 2 vacations. She reports she has been on the modality for 4 years and reports no complications or infections. Understanding and communicating with your patients about home modality options available will ensure a modality match that best fits your patient's need. Sharing your home modality knowledge regularly with patients and family members will bring these options to the forefront and encourage an atmosphere of home first. When a patient chooses to dialyze at home, they have more control over their schedule and can determine when they will complete their prescribed treatments. When they no longer leave home for their treatment, they can save time and transportation costs and be free of the tensions created with weather-related travel worries. The patient will spend less time sitting in waiting rooms with exposure to bacteria and viruses. The patient will have more time to spend with their family and friends and time to pursue their interests, hobbies, and work. Peritoneal dialysis uses the inner lining or membrane of the abdomen or peritoneum as a filter to clean the blood. Capillaries in the peritoneum act as the dialysis filter to remove fluids by osmosis and waste by diffusion. During treatment, dialysate is cycled into the patient's peritoneum through a small flexible tube that has been surgically placed called a peritoneal catheter or PD catheter. Glucose serves as the dialysate buffer and is available in 3 concentrations. Choosing a higher concentration of glucose in the dialysate encourages more fluid removal. All equipment, supplies, and training are provided. There are 2 PD options: continuous ambulatory peritoneal dialysis, known as CAPD, and continuous cycling peritoneal dialysis, or CCPD. Continuous ambulatory peritoneal dialysis, or CAPD, is dialysis that is done throughout the day with a series of manual exchanges. Dialysate solution passes through the PD catheter and into the peritoneum, where it dwells for several hours with the catheter clamped and completes a single exchange. The peritoneum acts as the dialyzer, and gravity is used to move the dialysate in and out of the peritoneal cavity. Exchanges are performed 4 to 6 times per day in 3 to 6 hour intervals as ordered by the physician. Lab work, the patient's size, residual kidney function, and the functionality of the peritoneal determine the number and length of exchanges. Each exchange takes 30 to 40 minutes to complete. Peritoneal dialysis is performed 7 days per week. Continuous ambulatory or continuous cleansing peritoneal dialysis, or CCPD, is dialysis performed using the peritoneal membrane, much like CAPD in principle, but uses a machine called cycler, not gravity, to perform the exchanges, and takes place at night while the patient sleeps. The patient will be trained to set up, monitor, maintain, and clean the equipment. Multiple bags of dialysate are needed to complete the 3 to 4 exchanges performed over the 8 to 10 hours as ordered by the physician. CCPD is performed 7 days per week, and additionally, an extra treatment or CAPD manual treatment may be needed during the day based on individual clearances. Patients need to understand the benefits and challenges associated with peritoneal dialysis to make an informed decision. Peritoneal dialysis is associated with greater preservation of residual kidney function and requires no needles to perform the treatment. Performing treatments daily provides renal replacement that is similar to natural kidney function and will allow for a more liberal diet and possibly fewer medication. The patient must have a peritoneal catheter placed and commit to the training needed to master the skills and techniques to complete their treatment while preventing complications and infections. Additionally, the patient must understand the time needed for setup, cleanup, and maintaining inventory, and complete all treatments as ordered. Home hemodialysis is very similar to in-center dialysis, but is performed by the patient or a care partner in the comfort of the patient's home. The blood is filtered through the capillaries in the dialyzer and the waste and extra fluid traveling across the membrane and is disposed of as waste down the drain. The patient has the ability to schedule their own prescribed treatment when it is most convenient for them. The dialysis prescription is written by the doctor based on the patient's size, residual kidney function, and lab work. Standard home hemodialysis treatments are performed 4 to 6 times per week for 2.5 to 4 hours each treatment. Receiving treatment more frequently improves clearances, reduces comorbid dialysis conditions, and these patients see fewer complications over conventional in-center dialysis treatment. The patient no longer needs to leave home for treatment, saving time, transportation costs, and alleviating travel concerns. Seen here are two equipment options, which both provide easy setup, teardown, and monitoring. Each machine is self-contained and provides medical grade water and dialysate necessary for each treatment. Training equipment, supplies, and 24-hour support are provided by the home dialysis team. The troubleshooting team from the equipment manufacturer also provides support. Nocturnal home hemodialysis is a slower, longer hemodialysis treatment that is performed by the patient or care partner in the patient's home while they sleep using the same equipment and principles as daytime home hemodialysis. Nocturnal treatments are longer and provide a modality option that is more like natural kidney function, giving the patient improved clearances, improved management of comorbid condition, fewer side effects, possibly requiring fewer medications, a more liberal diet, and the most daytime freedom to pursue the patient's passions. Patients may have many things to consider when choosing a modality option. Taking charge of their health and well-being is motivation to consider home hemodialysis. The benefits include spending less time traveling to in-center dialysis, performing their treatments on their own time, drawing their own labs, and using telehealth to communicate with the dialysis team. The patient may also have a more liberal diet and need fewer medication. Additional considerations include the patient and/or caregiver must commit time to attending training and have the ability to follow the procedures to avoid complications and infections. The patients will need additional time to set up and clean up daily treatments and time to maintain supplies, including inventory and ordering. The patient will need to have space for equipment and supply storage. To help alleviate limited storage space, supply deliveries can be scheduled more frequently. Creating and supporting a successful home program can be accomplished by incorporating proven best practices from leading home facilities. Education on home modalities for all staff should be a priority to encourage open conversations between staff and patients about modality choices, creating an atmosphere of home understanding in every dialysis facility. Staff should be given designated time to pursue facility-specific education, boot camps, or complete the ESRD NCC professional home education. Successful programs identify a home champion or a go-to person to promote the modality in every facility and include all members of the IDT team to support and promote home growth. Home education must be a priority. When early and intensive education is provided to incident patients in a transitional care setting, 50 to 70% of those patients transition to a home modality. Facilities who have adopted self-care units give patients the confidence and skill to enter a home program and be successful. Using the experience at different stations where patients can try the home equipment and experience more frequent dialysis in the in-center setting have seen even higher rates of home modality transitions. These facilities have encountered more open dialogue regarding home modalities and have increased patient interest, leading to waiting lists to try the technology. Programs that individualize and center their programs around the patient priorities and needs see exponential growth in their programs. Training and support may need to have expanded hours or alternate locations to accommodate these needs. Successful programs offer respite treatments to mitigate challenges and prevent burnout. Home modality education needs to be innovative and must take into consideration individual patient need and learning style. Peer mentors can be used to provide the patient's perspective and assure that the patient can master the skills needed to dialyze at home. This helps alleviate patient doubt and fear. Friends and family should be included to aid in understanding of the modality and provide encouragement to the patient. Patients who have the cognitive and physical ability or a competent care partner should have a chance to try home modality. Motivation is a driving force to success, and all motivated patients should have a chance. Patients who were previously ineligible for medical reason, housing, or other challenges should be evaluated as their priorities or previous challenges may have changed. Consider patients who are unhappy or acting out in the in-center environment, as loss of control could be a source of these behaviors. As we saw in the second case study presented, Louis Lipscomb thrived at home with home hemodialysis once he had control back in his life. Successful training and preventing loss of patients once they have transitioned to home is key to maintaining a successful home program. Alternative training strategies may be needed to account for differences in adult learning, and training days may need to be extended. Peer mentors may be used to provide encouragement and eliminate doubts and fears. Frequent review of the patient's state of mind, training, progress, and processes will assure that the challenges are identified and solutions are posed. Including patients, family members, and friends in all educational opportunities, and stressing education on the ability to travel on a home modality, assistance in making those travel arrangements, using telehealth, and providing respite assistance will encourage, support, and promote the advantages of home modalities to all parties. For additional information on home modalities, please visit the IPRO ESRD Network Program website, IPRO Learn, Home Toolkit, or additional websites identified in the following slides. Choosing the right treatment option will help your patient thrive on dialysis. These resources, along with other options, will help the patient choose a treatment option that best fits their priorities and goals. Review the Medical Education Institute Life Options. Refer your patient to Dialysis Organization treatment option classes, the National Kidney Foundation programs, or the IPRO patient portal for additional education. These network-created or ESRD NCC resources, including home modality pamphlets, handouts, resource guides, checklists, and videos about home modalities and telehealth, can be found in the IPRO Learn Home Toolkit and on the IPRO ESRD Network website. This slide provides the websites where all of the resources can be found. Thank you for taking the time to review the Home Education module. To receive the 1 CE credit for completing this course, you must take the post test and score at least 80% competency. Thank you and good luck.